Which of the following is the most appropriate initial pharmacology therapy for rapidly reducing circulating T3 levels in thyroid storm according to the American Thyroid Association guidelines? Methimazole, PTU, radioactive iodine, levothyroxine, amiodarone. This is a 35-year-old woman with history of Graves' disease. Graves' disease is an autoimmune disorder where the immune system produces antibodies that stimulate the thyroid to overproduce higher thyroid hormones, leading to a hyperactive state. Presents with fever, tachycardia, agitation, vomiting after discontinuing her hypothyroid medication or antithyroid medication. So what are we going to do? What are the signs and symptoms? We're going to have anxiety, tremors, heat intolerance. You can have a rapid or irregular rapid heartbeat, digestive, more frequent bowel movements, unexplained weight loss. You can have an enlarged thyroid gland. Eyes can be swelling, bulging in the eyes. That can be build up the hydrochloric acid behind the eyes. You can have edema, most prominently mixed edema, most commonly in the shins or feet. What's the answer? Give it PTU, propyltherazole, is the initial treatment of thyroid storm because it inhibits both the thyroid hormone synthesis and peripheral conversion of T4 to T3. Here's another question. Which of the following clinical, these are just short questions right here. Which of the following clinical features most likely characteristic of thyroid storm and helps differentiate it from uncomplicated thyrotoxicosis, mild tremor, bradycardia, mild organ failure, weight gain, or hypothermia? The answer is going to be multi-organ system failure. This is what's going to be more characteristic of thyroid storm. Thyroid storm, multi-organ system failure. Remember, altered mental status is a system. It's your CNS. You have altered mental status. Is organ failure, sign of organ failure in the CNS. In the management of thyroid storm, what should be given? When should inorganic iodine be given? This is potassium iodine. Be administered relative to antithyroid drug therapy. Before antithyroid drugs, while giving the antithyroid drugs, at least 1 hour after antithyroid drugs, only if antithyroid drugs are contraindicated, or never. And the answer is at least 1 hour after antithyroid drugs are administered. This helps stop thyroid hormone synthesis. We have the longer discussion this in the deep dive lectures, is that potassium iodine stops thyroid hormone synthesis. It's given 1 hour after the antithyroid drugs. According to the American Thyroid Association, what additional therapies should be included in initial management of thyroid storm to address possible relative adrenal insufficiency? Here we go, hydrocortisone. We briefly discussed this before. Hydrocortisone is recommended as a prophylaxis against relative adrenal insufficiency and may block the conversion from T4 to T3. All right, thyroid storm, real life threatening condition characterized by severe clinical manifestations by thyrotoxicosis with a high mortality of 15 to 20%. Several manifestations of severe manifestations of thyrotoxicosis with shock, hyperthermia, tachycardia, high output heart failure, and GI dysfunction. Clinical features: high temperatures can be as high as 41.5 degrees Celsius. Agitation, delirium, confusion, psychosis, seizures, stupor, and coma. Can have anything from nausea, vomiting, diarrhea, abdominal pain, and jaundice. Can have tachycardic, heart failure, atrial fibrillation. Precipitating factors: surgery, infection, trauma, acute iodine exposure, and then radioactive iodine therapy, ingestion of salicylates and pseudoephedrine. So excessive amounts of iodine-containing supplements. Some examples would be seaweed. So you feel like you're going to the health store and you say, I want to be healthy, and they go, well, you need to have some kelp. Okay, so kelp contains a ton of iodine, and you wouldn't think that this would be unhealthy. Maybe take more than what the label says. Maybe the label doesn't give the accurate thing. What's another medication that contains massive amounts of iodine? Amiodarone. Amiodarone does. Thyroid storm treatment. Goal is to decrease the peripheral conversion of T4 to T3 and reduce production of thyroid hormone. Thiamines are the beta and plus beta blockers are the mainstay of treatment. Propranolol plus PTU is the preferred agent for life-threatening thyroid storm. Once stable, the patient should switch to methimazole. It's less damage to the liver. Thyroid storm treatment continued. High-dose glucocorticoids reduce conversion of T4 to T3. Give after 1 hour, give the iodine drops to inhibit further release of thyroid hormone. Acetaminophen plus cooling blankets for hypothermia. Large doses of PTU plus a saturated solution of potassium iodine. Start 1 hour after PTU plus propranolol to control heart rate. Propranolol can be either IV or PO plus IV hydrocortisone. Continue discussion on thyroid storm. Best initial treatment, beta blockers. When iodine treatment is the best treatment. Thyroid storm, it reduces mortality by 40%. Fever, remember you're going to have fever, tachycardia, and the treatment is going to be steroids. Methimazole or PTU, we know PTU comes first and methimazole second, once stable. Then after 1 hour, give the potassium iodine. Get rolling with our next clinical scenario. This is a 77-year-old male with past medical history of diabetes mellitus type 2. So he's taking oral medications probably, and guess what? He's taking old school stuff because this is what they gave him. He continued this. What would be one of those medications? Probably sulfonylureas. So glyburide was probably what he's taking, and it's a long-acting sulfonylurea. He's noted for hypoglycemia, and this gentleman has been doing very good on his glyburide. And he goes on a cruise, and he has altered mental status and nausea, vomiting, diarrhea after the cruise. So he happened to be on the poop cruise. And he happens to have a large amount of diarrhea. So what happens when you have diarrhea and he's having nausea and vomiting with this? He's not able to take fluids in. They didn't want to give him IVs because he had beautiful skin, he had nice tans, and they didn't want to damage his skin, make him look unpretty, so they didn't give him IVs, so he didn't replete his fluids, and he's pooping everything out. He was taking glyburide, which he probably shouldn't take in his elderly patient. Remember, we have this Beers list for potentially inappropriate medications for older adults. It's a list of medications that healthcare providers should avoid, okay, and above the age of 65. So glyburide is on there as not being a good, safe medication for him. So he has sulfonylureas, which excessive doses can cause hypoglycemia, confusion, seizures, anxiety, tremors, diaphoresis. Significant prolonged hypoglycemia can occur from superthermic administration. Got to remember is these medications are going to be excreted through the urine. So in this gentleman's case, his kidneys have taken a hit because he has nausea, vomiting, and diarrhea, and he's not repeating, so he's going to have an AKI. So need to decrease, you need to, here again, we've had this discussion before, so he's going to accumulate in his body. So treatment is dextrose plus glucagon is the temporizing measure. Monitor for hypoglycemia for up to 48 hours if large ingestions. We've gone through this before. This is something that you should know. This is something very important that you will see in the real world. Maybe sulfonylureas will go away as we have newer, better medications. Here we go. This is an unfair board with question. Which of the following is most likely diagnosis? And your options are hyponatremia, thyroid storm, Addison's disease, myxedema coma. This is a 52-year-old male who's brought in by the emergency department by his son with extreme fatigue. His patient has history of hyperthyroidism, on treatment. On examinations, blood pressure is 100/52, pulse is 67, and temperature is 36. The laboratory results are glucose is 67, serum sodium of 131, potassium of 5.4, and TSH of 5.3. Waiting the results of serum cortisol. What is the most likely diagnosis? Let's get to the diagnosis. It's going to be Addison's disease. Addison's disease. So, as the history suggests of thyroid disease, autoimmune, well, let's go through this right here. So, in the findings of Addison's disease are syncope, lethargy, confusion, convulsions, hypotension, hypothermia, hyponatremia, hyperkalemia, hypoglycemia. What is the treatment? It's going to be IV fluids and corticosteroids. So, let's go through. Is he going to be hypothyroidism? Hyponatremia. Our sodium right here is not that low. So boom, we'll get that out. Thyroid storm. No, he's not bradycardic. He's normal rhythm, heart rhythm. So we're going to take that out. Myxedema coma. Well, we don't have the TSH results back, but we have the TSH at 3.5. This is very unlikely to be a myxedema coma, so it comes down to Addison's disease. Is this question fair? It is not fair. So this makes it more difficult. So this is this is the way boards are, is they kind of, you have to muddle through, and we work through each thing. We eliminate sometimes in some of these questions, eliminate the wrong to get to the right. Eliminate the wrong to get to the right. All right, let's go here and let's talk about primary adrenal insufficiency, aka Addison's disease. Flu, fatigue, hypotension, hyponatremia, hyperkalemia, and low blood glucose. You have increased ACTH stimulation leads to skin hyperpigmentation. It would have been nice if they put that in the question, but they know if we saw that, we key onto it right away. Can become acutely worsening by stressors, leading to adrenal crisis, shock, fever, abdominal pain, and altered mental status. Causes autoimmune disease. Now, patients, 90% of patients diabetes type 1 or have hypothyroidism, like our gentleman did, they can be triggered by infections, hemorrhagic infarcts, metastasis. So what would be the testing we could do is a complete overnight dexamethasone suppression test. We can check urinary catecholamines and methamphetamines, not methamphetamines, methamphetamines. If hypertensive, aldosterone to renal ratio can be calculated. If excessive hormones noted on labs, consider surgery. If negative, consider malignancy, get imaging, concern for malignancy. If any of the below, we'll go through this. If on imaging, adrenal nodule shows a greater than 10 Hounsfield units, we'll repeat these again. Mass greater than 4 centimeters, greater than 50% contrast retention 10 minutes after contrast administration. More discussion on primary renal insufficiency, how to diagnose, get ACTH, serum cortisol, high dose 250 milligrams ACTH stimulation test, corticotropin stimulation test. Primary adrenal insufficiency has a low cortisol, high ACTH. Secondary or tertiary adrenal insufficiency have low cortisol, low ACTH. Continued discussion of adrenal insufficiency is failure of the adrenal glands or inadequate secretion of cortisol from the adrenals from other causes. Primary adrenal failure disorder from failure of the production of hormones in the adrenal cortex, with autoimmune adrenalitis being the most common causes in 70 to 80% of the cases. Around 80% have adrenal autoantibodies, the 21 hydroxylase antibodies. Adrenal insufficiency, continued discussion. Signs and symptoms: weakness, vomiting, myalgias, arthralgias, postural hypotension, dizziness, salt craving, headache, memory impairment, skin pigmentation, fever, tachycardia, decreased body hair, amenorrhea or cold intolerance suggesting hypopituitarism. Diagnosis: decreased sodium, increased potassium, decreased glucose, eosinophilia can be also noted. AM cortisol less than 3 confirms. 3 to 18 do an ACTH stimulation test, corticotropin stimulation test could also be called that on a board question. ACT stimulation test with 250 of ACTH IV, and then measure cortisol at 0, 30, and 60 minutes. When you have these tests, when you do these inpatient, it's really hard to make sure that they get these done right. So you have to have the teams coordinated, including your nursing and phlebotomy, to make sure these are drawn accurately. Sometimes it's really hard to get these tests where the labs are drawn accurately. Peak cortisol less than 18 confirms diagnosis. More discussion on adrenal insufficiency. Addison's is an autoimmune disease. Best initial test. Morning cortisol. Cortisol should be spiking in the morning. You can look at 0 to 800 is probably the most optimal time to get it. Measuring ACTH after low morning cortisol. Do abdominal CT when the ACTH is elevated. Do MRI CT of the pituitary when the ACTH is low. Pituitary is not responding properly to low cortisol. Treatment: replace. Adrenal insufficiency causes: primary, autoimmune, most common. If you're in other countries, TB will be most common, or fungal infection. Amyloid can also be there, hemochromatosis. Secondary would be pituitary or hypothalamic disease. Given steroids by the providers, bilateral adrenal hemorrhage. Functional could be acute illness or septic shock. Hypofunctioning of the adrenal gland, we're going to divide this right down the middle with our fancy drawing. All right, let's go through here. Look at that fancy drawing. All right, in primary, plasma cortisol is going to be low. ACTH level will be high. Skin pigmentation, yes. Hyperkalemia, yes. Volume contraction, yes. Salt wasting, yes. Aldosterone level, low. Okay. Hyponatremia, yes. Treatment, hydrocortisone, fludrocortisone. Remember, primary adrenal function is caused by a problem with the adrenal gland themselves, leading to insufficient production of cortisol. Secondary adrenal hypofunction is from insufficient signals from the pituitary gland, or specifically ACTH or hypothalamus. So pituitary or hypothalamus. Secondary, let's go through this. Same is going to be plasma cortisol, both going to be low. ACTH can be low or normal. Skin pigmentation, not going to have it, no. Hyperkalemia, no, not going to be there. Volume contraction, no. Salt wasting, no. Aldosterone level, normal. Can have hyponatremia with SIDH, and treatment is going to be hydrocortisone. Adrenal insufficiency, outpatient stress dose steroids. So what do you do for patients who have adrenal insufficiency? To avoid having them come into the hospitals, you would do, if they have stress, they're stressors, meaning they get sick, you need to double their dose of stress, their normal steroids. Inpatient stress dose steroids, recommendations would be 50 q 6 hours with IG hydrocortisone. Continue discussion of primary adrenal insufficiency. Major cause in the US is going to be autoimmune adrenalitis. I know we're repeating these things, but this is important stuff. Positive 21 hydroxylase antibodies in 90% of the cases. If negative, get abdominal CT imaging. Autoimmune disease can have atrophic adrenal glands noted on imaging. Normal will have possible infiltrated disorders such as lymphoma, sarcoidosis, histoplasmosis, or TB. Bilateral enlargement could be a sign of adrenal hemorrhage. Low serum cortisol level, elevated ACTH, risk for hypothyroidism, primary ovarian insufficiency, diabetes mellitus type 1, and celiac disease. Treatment, glucocorticoids. Fludrocortisone, well, we talked about it, only needed for primary adrenal insufficiency. In secondary adrenal insufficiency, there is no mineralocorticoid deficiency. This would be an important or easy board question for you to get. If someone has, they give you where the patient, his skin is tan and they have signs of primary adrenal insufficiency. So tan skin and they have signs of adrenal insufficiency, you would give fludrocortisone. Say they take away the tan skin, it'd be a secondary adrenal insufficiency, no mineralocorticoid deficiency. Steroids and cortisone stimulation test. Almost all steroids cross-react with the assays for serum cortisol with the exception of dexamethasone. If the treatment is already given, the cortisone stimulation test and cortisol may be helpful as the outside steroids will invariably suppress the AM cortisol. Options for treatment, including still testing if the pituitary axis is intact with a cortisone test. Use dexamethasone. This will not cross-react with the assay. Use hydrocortisone and hold the dosing prior to testing. Nighttime dose is the most physiologic and has a minimal corticoid. Cortisone stimulation test. High dose, 250 milligrams of corticotropin is the standard, and it has a 98% sensitivity for primary adrenal insufficiency. A normal dose, the SIM test, I know we talked about these, but we're going to repeat these because these are important. Adrenal insufficiency, a normal high dose results in a rise of serum cortisol up to 18 at either 30 minutes or 60 minutes after stimulation. Using both time points can prevent overdiagnosis of adrenal insufficiency. Some people respond late. They're late peakers. That's why you do the 0, the 30, and the 60. 0, you get the baseline. 30, you get the second. And then some people are going to be later, not get that full 18 up until the 60-minute mark. AM cortisol at this threshold, at the threshold of 3 to 5, is extremely specific and can rule in adrenal insufficiency. Low AM cortisol, when it should be peaking, should be very specific. Per Endocrine Society, 3 is very specific, okay? So remember, roughly 8 in the morning is going to be our highest or peak cortisol level. Remember, cortisol is hydrophobic and circulates with binding hormone. Measured cortisol levels should be high or low, binds to albumin. So both of these are made in the liver. Disease affecting the liver will affect the levels of albumin and cortisol binding protein. Also affects the level of cortisol. Cirrhotics will overestimate the level of adrenal insufficiency. A third diagnosis is cirrhotics, but when the measured salivary, when you get the salivary cortisol, free cortisol level, only 9%. So meaning because in cirrhotics, they have decreased albumin and decreased cortisol binding protein, they're going to overestimate the level of adrenal insufficiency by a significant amount. So cirrhotics, we want to consider measuring the salivary cortisol. At the threshold of 15, AM cortisol is extremely sensitive and can rule out adrenal insufficiency. This value successfully predicts normal adrenal function.